Okay, so we are now going to continue with the last couple of lectures, last couple of audio lectures until we get to the final. So in Blackboard, you have hearing and balance disorders, and then you have care of the client with visual and hearing problems, and then there's a separate PowerPoint with eye and vision disorders. So I generally go over the hearing and balance disorders, and I also go over the eye and vision disorders. I do not go over the care of the client with visual and hearing problems because that information is actually repetitive. Um, Sometimes we actually just give you a handout in terms of our hearing and eye disorders. Um, but I think these slides are actually really good because they give you a lot of information that may help you later on when you're studying for your NCLEX. So I've kind of just kept the PowerPoints. So when it comes to the ear, it is incredibly important to me that you understand what the different structures are for the external ear, the middle ear, and the inner ear. Depending on where there is a problem, you are going to get different types of medical conditions, and you're going to get different types of treatment. So it's extremely important that you're able to kind of visualize all of that and keep everything kind of in its own separate kind of compartment. So in your Blackboard, I've given you a handout that is labeled ear. It's a PDF, and literally it's the same information that's in your slides, but I've kind of just categorized the information for you. So it's so you're going to see that I have external, middle, and inner. So while I'm doing this right now, I need you to just make sure you have a copy of that. You've printed it out, and I'm going to read what is on the handout just so you understand my writing. All right, so I'm going to start with the external ear compartment going all the way down. So for the external ear, what are our structures? So it's our auricle and our external auditory canal. All right, those are the two main structures. And then what types of problems what types of things can be an issue for us in the external ear? So we see that you can have cerumen impaction, which is basically wax, and the fact that somebody can put foreign bodies into your external ear. So those of you that have kids, this probably sounds familiar. Like your kids usually stick everything in their ears, right? And that can end up being a really big problem. The other issues that we might encounter in the external ear are things like external otitis, or they may also call it otitis externa, all right? And this is just basically an inflammation of the external auditory canal, okay? And of course, you're paying attention to the word external, right? So that's a hint for you that that's on the external ear. And then your patient can also have something that is known as malignant external otitis. So obviously that's like anything malignant that's like really bad. So obviously that's worse than just having an external otitis. All right. Perfect. And then for the middle ear, we are going to look at what our structures are. So we have what is known as the eustachian tube, we have the tympanic membrane, and the other name for the tympanic membrane is your eardrum, right? And then we have the ossicles. So they're the three smallest bones in your body, and they are known as the malleus, the incus, and the stapes. So we want to highlight the stapes because this is where you can end up having a problem known as otosclerosis. And in otosclerosis, what happens is you get this abnormal kind of spongy bone growth that happens, and then the stapes is not able to have efficient transmission of sound from, let's say, the incus all the way down to the inner ear. So that no longer is able to happen, all right? So what they would have to do is they would have to do what is known as a stapedectomy. And so we'll explain what a stapedectomy is in a little while. So in the middle ear, you have the eustachian tube, the tympanic membrane, also known as the eardrum. You have the ossicles. So they comprise of the malleus, the incus, and the stapes. And we're concerned about the stapes because this is where we can get otosclerosis. All right. So what are the issues that we can get in the middle ear? So you can get what is known as tympanic membrane perforation, Okay, and we came across the tympanic membrane perforation when we talked about blast injuries in disaster and emergency nursing care, right? Patients can have what is known as acute otitis media, they can have what is known as serous otitis media, and chronic otitis media, and they can also have otosclerosis, which I mentioned to you already. So you're also paying attention to the word media at the end of each of these different types of conditions, because that's a hint for you of where the problem is in relation to the ears. Okay, so the different types of surgeries that they can do, you know, in a patient that has a middle ear disorder. So these are the main ones that may happen. They can do what is known as a tympanoplasty. They can do what is known as an ossiculoplasty. And once again, you're paying attention to the root of the word. So tympanoplasty is the tympanic membrane. Ossiculoplasty is the ossicles. They're doing something to ossicles, right? They can also do what is known as a mastoidectomy. Okay, so there is a chart in your book. It's chart 64-7, and usually when they're doing a mastoidectomy, it's usually because the patient has some type of diseased bone, and they're basically trying to get removal of that diseased bone, and they're trying to basically create a new and healthy ear. They can also do a mastoidectomy for what is known as a cholesteatoma. So this is spelled Cholesteatoma. And apparently this is like an abnormal non-cancerous skin growth behind the eardrum. And they may describe it almost like a cyst in some cases. So just know that these are like, conditions why they may do a mastodectomy. I really highly would like you to look at chart 64-7 to see what the nursing care is for a patient after mastodectomy. The other we mentioned number 4 here, stapedectomy. We mentioned that they can do that for the otosclerosis. So here, all they're doing is that they're taking out the stapes. They're putting in a graft or a prosthesis there, and then the prosthesis that they put in allows for conduction between the incus and the inner ear. They can also do what is known as a myringotomy. So myringotomy. Myringotomy. So with this, anytime you see the word otomy, you know that there's some type of hole being made. So with this one, they're putting an incision in the tympanic membrane to relieve pressure or to drain purulent fluid that is there. So this apparently takes only about 15 minutes, and it usually heals within 24 to 72 hours. So you're noticing that under the middle ear is where we're getting a lot of surgeries that can potentially be done. All right. Yeah. Okay, and then for the inner ear, so our structures include the cochlea, which is basically protected by what is known as a bony labyrinth, and where our other structures that we're interested in include cranial nerve number 7, cranial nerve number 8. So you want to go back to your neural and you want to remember what these cranial nerves are responsible for, right? So if we have problems, the cranial nerves number 7 or number 8, what is the problem that we're going to see, right? So, and the vestibulocochlear nerve also we're concerned about, okay? And then, so these are the structures in the inner ear. And then we're looking at, okay, what are the issues and what are the problems that we can see when somebody has an inner ear disorder? So we have things like tinnitus, we have things like labyrinthitis, we have things like benign positional vertigo, we have ototoxicity, we have acoustic neuroma, which is a tumor on cranial nerve number 8. And then the other big problem that we see in people with inner ear disorders is Meniere's disease. So highly, highly recommend that you look at page 1933, and it is chart 64-8 that basically is talking about the dietary guidelines for a patient with Meniere's disease. So we're going to talk about what that is later on as I go through the PowerPoints. All right. So at the very beginning, guys, you want to make sure you have this chart written out, whichever way you want it. You want to write it out, but really be able to see where all these different structures belong. All right, and then here we just have a whole bunch of different objectives that we're going to be talking about today in terms of the ear. So you can read all of these individually and just look at them. This slide does include some of the visual disorder kind of goals, but like I said, I've kind of separated these things so that it's easier for us to manage for right now. All right, so then the next couple of slides are basically just going over the different structures. So this is the anatomic and physiological overview. So we've already mentioned what's in the external ear. So we said it's the auricle, and some of the functions are collecting sound waves and vibrations. Then we have the external auditory canal, at least 2.5 centimeters long. It's dense fibrous framework. Let's see, there's hair, sebaceous glands, and ceruminous glands in there as well. So once again, this is just very loosely. You don't have to memorize these, but at least know that in the external ear there's an auricle and an external auditory canal. For the middle ear, you know that it's an air-filled cavity, right? So some of the structures we mentioned already were the eustachian tube, which equalizes pressure in the middle ear with that of the atmosphere. We know that there's a tympanic membrane or the eardrum, and we know that this is 1 centimeter in diameter, protects the middle ear, and it's basically conducting sound vibrations from the external canal to the ossicles. We've mentioned what the ossicles are. So it's the 3 smallest bones in the body, and it's the malleus, the incus, and the stapes. For the inner ear, we know that it's deep within the temporal bone, and so you want to start, I guess, looking at your anatomy and physiology once again and getting a visual of what the temporal bone looks like and where it's located. So it consists of the cochlea, which contains transducer for hearing, semicircular canals, contains receptor organs for balance. We have cranial nerves 7, facial, and 8, the vestibulocochlear nerve, right? And all of them are protected by the bony labyrinth, which we mentioned already. All right, so here you just have a picture of what all of that looks like. So you want to just spend some time to see whether or not you're pretty good with looking at this. All right, so what are the functions of the ear? So it's basically hearing, and this is primarily conducted over 2 pathways. So we have air being one pathway. So sound travels over air-filled external and middle ear through vibration of the tympanic membrane and the ossicles. So the air pathway apparently is a more efficient pathway, unless there's a defect that interrupts the pathway where the patient has some type of hearing loss. So bone is another pathway, and here sound travels directly through bone to the inner ear, and it bypasses the tympanic membrane and the ossicles. So that's another way that we're able to get hearing, right? So other functions of the ear, so balance and equilibrium, and none of this should be weird for you. So body balance maintained by proprioceptive system, the muscles in the joints, the visual system, your eyes, and the vestibular system, which is a labyrinth. So remember what proprioception is. So this is where, like, you would ask your patient to close their eyes, and then you'd grab their hand, let's say ask them to put their hand out, and then you'd grab one of their fingers and you'd point it up or down. So remember their eyes are closed, and then you'd ask them, can you tell me if your finger is up or is down? So that's proprioception. They should be able to tell you that the finger is up if it is up. Okay. In terms of assessment and diagnosis, so not much here. You're just looking at the external ear and you're looking for any abnormalities. So inspection and direct palpation of the auricle. So you're looking for deformities, lesions, discharge, how big is it, symmetry and tenderness. So all the usual regular boring things that we normally do. All right, and then there's an otoscopic examination that can be done as well. So your auricle is gently pulled back to straighten out the ear canal. You put the otoscope speculum into the ear canal, and your healthy tympanic membrane should be pearly gray. All right, so here you have a picture of a normal tympanic membrane versus a perforated tympanic membrane. So pretty big difference. All right, so evaluation of the auditory acuity. So how well is the patient able to hear, right? So everything on this slide is important, and you have to be able to kind of have a really good understanding of this as well. So for the whisper test, it's exactly what it sounds like. It's a whisper. So what you're going to do is you're going to occlude one ear, right? So you're going to cover one ear, and then you're going to stand on the side of the unoccluded ear, about 1 to 2 feet, and you're going to whisper something to the patient, and the patient should be able to tell you exactly what you said. All right, and then you're going to close the other ear, and you're going to do the same thing on the other side. So you're whispering something to the patient, you're 1 to 2 feet away from the unoccluded ear, and they should be able to repeat exactly what you said. That's exactly, like, don't complicate that. That's literally all I would want you to be able to remember. And then there is what is known as a Weber test. So for the Weber test, right off the bat, I want you to know that you are assessing bone conduction. So for the Weber test, what you're doing is you're using a tuning fork, you're hitting it, and you are basically trying to see whether or not the patient can hear the sound the same in both ears. So the Weber test uses bone conduction to test lateralization of sound. So lateral, it's going to both sides. You're trying to see whether or not the patient can hear it. So using a tuning fork, they use 512 Hertz, Hertz, abbreviated HZ for the tuning fork. So you grasp it, you hit it on your hand or your knee, and then you place the tuning fork on the head or the forehead. So in order for you to assess bone conduction, you have to place the tuning fork directly on the skin, right? So you put it on the head or you put it on the forehead. So a person with normal hearing hears the sound equally in both ears, or describes the sound as centered in the middle of the head. So a person with normal hearing hears the sound equally in both ears, or describes the sound as centered in the middle of the head. A person with conductive hearing loss, remember we're looking at bone conduction, a person with conductive hearing loss, such as from otosclerosis or from otitis media, hears the sound better in the affected ear. So they're going to say, oh, it was louder in this ear, it wasn't the same, or it wasn't in the center of the head, it wasn't the same, right? So a person with conductive hearing loss, such as from otosclerosis or otitis media, hears the sound better in the affected ear. And then you can also assess with things like sensory neural hearing loss. I'm not going to get into that for now. We'll just leave it at bone conduction, and you should be able to just tell me what the normal person hears and what a person with conductive hearing loss hears. All right. And then they have also what is known as a Rinne test. Rinne. So this one is assessing for both air and bone conduction. So it's both of them. All right, so for this one, it's the same thing. You're getting a tuning fork, and what you're going to do is you're going to change it between two positions. So you're going to hold the tuning fork after you've hit it, and it's vibrating. You're going to hold it 2 inches from the opening of the ear, so 2 inches away from the opening of the ear. So at that point, you're assessing for air conduction. And then you're going to move it and put it on the mastoid bone. So anytime you're putting it directly on the skin, you're looking at bone conduction. So Rinne is assessing for both air and bone conduction. And there's two positions. You're going to put it 2 inches from the opening of the ear canal, and you see what the patient says to you. And then you're also putting it against the mastoid bone. All right. So what should the patient be reporting to you? Okay. So as you're changing the position, the patient is asked to indicate which tone is louder or when the tone is no longer audible. All right. What the patient should say to you is, a person with normal hearing loss reports that air-conducted sound is louder than bone-conducted sound. That is literally all I want you to remember. I want you to remember that for the Rinne test, you're assessing for both air and bone conduction. You're putting the tuning fork at least, at least 2 inches from the opening of the ear canal, and then you're putting it on the mastoid bone. And then when you ask the patient what did they hear, they're going to say to you, a person with normal hearing is going to say that the air conducted sound is louder than the bone conducted sound. And then a person with conductive hearing loss hears the bone conducted sound as long as or longer than the air conducted sound. So if they have conductive hearing loss, they're going to say it sounded the same to me. It sounded the same to me. There really wasn't any difference. I heard it for as long as I heard it when you put it by my ear. I also heard it the same amount of time when you put it next to my mastoid bone. Or they're going to say that they heard it longer they heard it longer than the air conducted sound. All right. So Rinne test is useful for distinguishing between conductive and sensory neural hearing loss. We're now focusing on sensory neural, right? The only two things I want you to remember are a person with normal hearing reports that the air conducted sound is louder than the bone conducted sound, and a person with conductive hearing loss hears the bone conducted sound as long as or longer than air conducted sound. So I would also encourage you maybe to Google it and see how they actually do this. Right? But really the main takeaway is just know what is normal and what is abnormal. That's the main things I'd want you to remember. All right, so in terms of, you can actually just not pay attention to this slide. What I want you to do is go to page 1920 and look at figure 64-5. So it's going to show you what the Weber test looks like and what the Rinne test would look like. All right, so just go to that. And remember, we're not doing sensory neural. We're focusing on bone conduction for Weber, and then for the Rinne, we're looking at air and bone. All right. So other diagnostic evaluations, so they can do an audiometric testing as well. So they have what is known as a pure tone audiometry. So here you're using sound as a stimulus, or you're using a musical tone. So the louder the tone is, before the patient perceives it, the greater the hearing loss, and that makes sense. So maybe you can have music, you play music, or you hit a charm or something, and you're expecting the patient to hear it, but maybe you have to hit it really, really loud, or play a musical tone really, really loud before they hear it. So obviously, the louder the tone before the patient perceives it, the greater the hearing loss, and that makes sense. They can also do speech audiometry. The spoken word is used to determine the ability to hear and discriminate sounds and words. You're speaking to the patient, and you're just kind of looking to see whether or not they understand what you're saying. So there's a middle ear endoscopy. So this is performed to evaluate suspected fistulas and new onset conductive hearing loss, and it can usually be performed in the doctor's office. So endoscopy, you know what that is. So that's a scope, and they're looking around. All right. So hearing loss, a lot of people in the United States have irreversible hearing loss. You don't have to memorize the numbers, especially if we're living in places like New York City, right? This becomes an even bigger problem for us here. So for conductive hearing loss in particular, people usually get that because of external ear disorders. Examples given are impacted cerumen or middle ear disorder such as otitis media or otosclerosis. So what are some of the things you may expect to see in a patient who can't hear or who has hearing loss? So, well, they can't hear properly, right? They have a sense as a patient that their own voice sounds different or it sounds weird. Maybe they'll report that it's easier for them to hear out of one ear than out of the other ear. They may report things like having sensations of pain in one or more, or in one or both ears. And if they have like sensory neurotypes of signs and symptoms, they're going to say that whatever they're hearing is very muffled. They may complain of things like vertigo, nausea, tinnitus, those types of things, right? And so some patients may actually end up needing to have a hearing aid, if it's really, really bad. So we do have some risk factors for hearing loss. So family history of sensory neural impairment, congenital malformations of the ear structure, low birth weight, use of ototoxic medications, which at this point you're very, very familiar with, recurrent ear infections, bacterial meningitis, chronic exposure to loud noises. And this is definitely true for me. I live in Harlem, and every 2 seconds there's like an alarm going off or the fire truck going off. It's just so like exhausting. I honestly cannot wait until I move to a farm country or something. If you've had a perforation of the tympanic membrane, all of these are risk factors for hearing loss. All right. So sensory neural hearing loss. So this is neural. So remember the nerve. So this is deep, deep inside um, the ear, right? So usually results from damage to the cochlea or the vestibulocochlear nerve. And then you can have what is known as mixed hearing loss. This is both conductive hearing loss and sensory neural loss resulting from dysfunction of both air and bone conduction. Right. So more clinical manifestations when somebody has hearing loss. So things like tinnitus, a need to turn up the volume, inability to communicate. If you have students in a classroom, sometimes, especially little kids, they may act out, they may be inattentive, they're uninterested, and maybe they're having failing grades, they're missing parts of a conversation. And often the people around the patient are the ones that recognize the impairment first. In older people, though, they try to pretend like they can hear everything, and I've experienced this like in nursing homes when I used to take students there, and like people are very proud and they don't want to admit that they can't hear. So they would miss like a whole bunch of a conversation. They'll try to dominate the conversation. And then you'd be like, what are you talking about? Because what they're talking about is not even close to what you said, but they just don't want to admit that they have no idea what you're saying. So it's really important when you're teaching to have them repeat everything or do return demonstrations because you think they got it and they'll nod their head and they heard nothing. All right, so how are you going to assess for hearing loss, right? So you're going to look for things like speech deterioration, fatigue, indifference, social withdrawal. Some patients will become very insecure, right? They'll have indecision, they'll be procrastinating, they're very suspicious of everything because they're not understanding what you're saying and they can't hear it. They'll have a sense of false pride, and that's what I used to see a lot in a nursing home. Things like loneliness, unhappiness, and some of them want to overcompensate and they want to kind of dominate the conversation. Okay. So environmental factors, so this affects all of us. Over time, results in permanent sensory neural hearing loss. So noise is a potentially dangerous source of physical and psychological damage, so especially loud, persistent noise. So what does that noise do for us? It's constricting your peripheral blood vessels, it's increasing your blood pressure and heart rate, and it increases GI activity as well. So that last bullet is kind of a weird thing, but apparently they've done like some studies, and patients that work in really noisy environments report things like nausea, and that they're more prone to having incidences of digestive disorders, things like gastritis and even ulcers. So that is really, really interesting. There's what is known as noise-induced hearing loss. So this is hearing loss that follows a long period of exposure to loud noises. Acoustic trauma. So this is hearing loss caused by single exposure to an extremely intense noise, such as an explosion. So we talked about some of this under, well, an example could be under the blast types of injuries that we talked about earlier in emergency and disaster nursing. So OSHA has come to the rescue and requires workers to wear ear protection to prevent noise-induced hearing loss. Okay, so older people, they have issues. You don't have to remember the percentages, but know that they're more prone to be hard of hearing, and if once the older they get, like half of them have they're hard of hearing. So some of the other issues why is they have hardening of the cerumen, their tympanic membrane can atrophy, become sclerotic, so that normal transmission is no longer there. Cells at the base of the cochlea degenerate. They've been alive for a very, very long time, so they've been exposed to loud noises. They've taken different types of medications, all those types of things, and all of that makes sense. All right, so healthy hearing is always a goal. So we're up to like healthy hearing and healthy people 2020 up to this point. So just know that this is always something that we're focusing on as well. Nursing management, so communication is key, right? So you want to understand the different types of hearing loss. Loud voices often make communication worse. Communication barriers cause other healthcare problems to go unattended. So you probably want to just really assess how your patient will best be able to understand what you're saying. So if they can't hear, then what are the alternative types of communication can we come up with, right? We do have a legal responsibility to make accommodations for patients' inability to hear. So we have sign language interpreters, and nurses need to work with patients and their families to establish effective means of communication. So, I mean, all they're saying here, like that weird sentence that said loud voices often make communication worse, is that, if in a noisy room, you're not necessarily going to hear what other people may be saying, right? So you just want to be able to, figure out, okay, on a patient by patient basis, just you and them, speak normally and see if they're able to hear you, find out if they're hard of hearing. You'd have a sense or an idea, I guess, if they've been tested already. But if you notice that your patient is maybe becoming more inattentive and they're acting like they're not hearing you, then you want to refer them to right people to basically assess them. And it's not the best thing to put them in another room with other people that are just yelling or screaming. That's not going to help, because then that's like noise pollution as well, right? So this last bullet you can ignore. This was from a different text. A comparable chart is on page 1925, and it's chart 64-5. So it's communicating with people who are hearing impaired. All right, and now we're going to talk about some of the disorders that are unique to each location. All right, so for the external ear, we already mentioned wax accumulation, and these patients will basically report what is known as otolgia. So this is a sense of fullness or pain in the ear with or without any hearing loss. So what do we do with the wax? Well, we can do irrigation, use warm glycerin, mineral oil, or half-strength hydrogen peroxide. They can suction it out. They can do instrumentation and just gently kind of try to take some of the wax out. There are medications that they can give you. It's liquid medications they can put in there, and you hold it in your ear, and then you kind of, when you bend your ear, like some of it kind of comes right out. So external ear, they can also put foreign bodies. So we've talked about this specifically under children, or even insects going in there. So there could be no symptoms at all, or severe pain and decreased hearing. So some of the management is the same, just getting whatever is in there out, basically. So they can do like irrigation, suctioning, or instrumentation. So instrumentation, they're using something like a tool to basically take out whatever is in there. If it's really bad, you may have to go under general anesthesia and get it taken out, because kids are happily trying to stick pencils and everything else in there, and who knows, they may jam something in there and then it breaks, right? So that's not a good thing. The external otitis or otitis externa, so this is an inflammation of the external auditory canal. So it can be caused by several things. So water in the ear canal, known as swimmer's ear, trauma to the skin of the ear canal, introduction of organisms to the tissue in there, dermatitis such as eczema and psoriasis, allergic reactions, hairspray, hair dye. Some of the things that your patient will report include pain, discharge from the external auditory canal, pruritus, feelings of fullness, and sometimes the discharge can be foul smelling. Okay. Your medical management is aimed at relieving the discomfort, reducing swelling of the ear canal, and eradicating the infection, right? That could have caused the inflammation, right? So analgesics to help with pain management if needed. If it's edematous and swollen, they use what is known as a wick. They insert that to keep the ear canal open for liquid medications. So they can give antibiotics or corticosteroids. So the wick itself is basically like a sponge or a tube that they used to give antibiotics. For malignant external otitis, it's more serious. It's a rare external ear infection, apparently primarily from temporal bone osteomyelitis, and it occurs in patients with low resistance to infections. So some of the things they have to do, so you know it's a bone infection. So this is going to be like, it's not going to heal very easily, because remember we already mentioned when we're talking about musculoskeletal that the bone is not very vascular, right? So sure, there's going to be intravenous antibiotic therapy, but they may need things like aggressive wound care and debridement to get to the actual bone, right? To take it out, essentially. And then they can also get other conditions, masses of the external ear, so basal cell carcinomas and squamous cell carcinomas as well. Okay. So for the conditions of the middle ear, we also can get a tympanic membrane perforation, and you can get this from trauma or a severe blow to the ear, or maybe they inserted like a foreign object in there and jammed it in there. We talked about blast injuries, right? That can also cause this, or explosions rather. Any of those things can be an issue here. If you have an infection, pressure buildup, then you can get things like a tympanic membrane perforation. If you're lucky, it's going to heal spontaneously within weeks of rupture. If not, then you're going to do a tympanoplasty, which is a surgical repair of the tympanic membrane. So if it doesn't heal by itself, then you are going to be doing that. So a tympanoplasty, you're basically closing the perforation, and afterwards you just want to prevent infection, and hopefully they're able to heal better. So this is just a surgical reconstruction. So for the acute otitis media, this is an acute infection of the middle ear. Apparently it's most common in children. The patient may have drainage or not, and this can be treated by oral antibiotics. If they have drainage as well, then they can also do ear drops with it. Then let's see, so they can do what is known as a maryngotomy. So this is a tube insertion to equalize the pressure behind the tympanic membrane. So surgical procedure in the eardrum to relieve pressure caused by excessive buildup of fluid or to drain pus, right? So we had given a definition earlier. So that's the main thing, just takeaways, equalizing pressure. And some of the things that can cause this are viral or bacterial infections. If somebody's getting a lot of upper respiratory infections, then this is part of the issue. If they're getting a lot of bacterial infections in particular, apparently the patients can end up with conductive hearing loss from this as well. And I also would want to add otosclerosis. I don't think I have it on this slide. So under the middle ear, remember I mentioned it in the on the chart I made for you. So the other condition I'd want to add is otosclerosis. We know that it involves the stapes, and we know that you get new abnormal spongy bone, and this prevents efficient transmission of sound. And the stapes cannot vibrate and carry sound from the malleus or the incus to the inner ear, right? So it's not transmitting the sound like it should be. Otosclerosis can involve one or both ears, and it can manifest as progressive, conductive, or mixed hearing loss. The patient may or may not complain of tinnitus. They, 'Cause, 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 when you're assessing for this condition with your testing, when we're assessing for this condition, sorry, I lost my train of thought. A person with conductive hearing loss hears the sound better in the affected ear, right? So we had mentioned this under the Weber test. So I just want you to remember that. So the main treatment for otosclerosis, in terms of surgery, they can do like a stapedectomy. So it's removal of the stapes. And they can basically insert a prosthesis in there to get better sound conduction. So all of this we've mentioned already, but I just want you to be able to remember that otosclerosis is the one that belongs under the middle ear, like one of the main problems here. Another medication that your book mentioned under medical management was that they can give sodium fluoride, apparently, and this is helpful in preventing breakdown of bone tissue. You don't have to memorize that either, but just thought I should mention that as well. Okay. All right, so just a picture of putting eardrops in an adult patient. Okay, and then conditions of the inner ear. So for this one, what are we seeing? So we're seeing motion sickness, which is a disturbance of equilibrium caused by constant motion, and we are paying extra special attention to Meniere's disease, which is an abnormal inner ear fluid balance. So what are we going to be seeing with the patient in Meniere's disease? We're seeing things like tinnitus, a roaring or ringing sound, vertigo, the perception or illusion of motion of the person or the surroundings, and this is primarily treated with diuretics and antiemetics. So let me see here. So for the Meniere's disease in particular, you're going to look at the other PowerPoint that has both hearing and vision, and near the end there's like 2 slides that are talking about Meniere's disease. So that slide describes Meniere's disease as an abnormal inner ear fluid balance caused by malabsorption of the endolymphatic sac or blockage of the endolymphatic duct. So what you're going to see in terms of manifestations, what are you going to be seeing here? You're going to be seeing like things like progressive hearing loss, tinnitus, feelings of pressure or fullness, episodic incapacitating vertigo that may be accompanied by nausea and vomiting. And all of these signs are basically fluctuating, and they may also complain of things like I mentioned, I think, episodic vertigo already. Yeah, episodic vertigo is part of this as well. All right. So this is also the condition that I wanted you to look at the chart for in terms of the dietary guidelines, because there's issues with having too much sodium, apparently. So in terms of treatment, so you want to make sure the patient is on a low sodium diet, and then some of the medications that they use include things like Dramamine, what is this? Antivert, tranquilizers, diuretics, and then if necessary, they can do surgical treatment to basically eliminate attacks of vertigo. So hopefully they don't have to do all of that. And what they would do is an endolymphatic sac decompression, middle and inner ear perfusion, and vestibular nerve sectioning. So you don't necessarily have to memorize that particular last bullet that is in the other slide. Okay, there's just 2 slides there. So for Meniere's, have a sense of what it is, what's causing it, which is malabsorption of the endolymphatic sac or blockage of the endolymphatic duct. You're going to see, have a sense of some of the manifestations, and you're going to look at your dietary guidelines and the chart just to get a sense of what may be going on. Let me see. Your book also, I think, mentions things like diazepam, Phenergan, as potential medications as well. All right, so then the next couple of slides just talk about all the things that can be a problem for your ears. And here we're specifically just highlighting medications. And I'm not going to mention all of these. Some of them you know about, some of them you don't. Yeah. So chemicals like alcohol, arsenic, for our purposes, we really want to be familiar with the aminoglycosides, antibiotics. And then here you have some other stuff that can also be an issue. All right. So for chapter, this is what, chapter 64. I've given you the charts to look at. Let me just see if there's any other. Well, you should always be looking at the charts because they give you a good way of minimizing the issues. So on page 1923, there's assessing hearing loss. That looks good. And then I told you about chart 64-5, communicating with people who are hearing impaired. Then there's the risk factors for hearing loss. That's chart 64-3 on page 1924. Prevention of otitis externa. This is page 1927. Let's see, self-care after middle ear or mastoid surgery. So this is important for you guys to look at in terms of what you're going to be teaching the patient after they've had mastoid surgery. All right, so taking antibiotics as prescribed, avoiding nose blowing for 2 to 3 weeks after surgery, sneezing and coughing with the mouth open for a few weeks after surgery, avoiding heavy lifting more than 10 pounds, straining and bending over for a few weeks after surgery. Be aware that popping and crackling sensations in the operative ear are normal for approximately 3 to 5 weeks after surgery. And then there's some other stuff here, so just finish reading this thing over here. And then dietary guidelines for patients with Meniere's disease. I told you that one already. And then there's another slide, tips for hearing aid care. Let's see. No, it's okay. You don't have to worry about that one. And that's it. So this is just the hearing aids. Okay. So the hearing aid is on page 1939. So tips for hearing aid care, chart 6413. Just very loosely, you can just read over this. That's it, I think.